Good morning, good afternoon, and good evening. Welcome all of you to this live program at Orthopedic Principles. Today, our guest of honor is Dr. Saurav Shah from Boston, Massachusetts. Dr. Shah is an attending orthopedic surgeon at the New England Baptist Hospital in Boston, Massachusetts. He currently serves as the Director of Education Research for the Sports Medicine Fellowship, where he was awarded the 2020 Teacher of the Year Award. Dr. Shah received his medical degree from the Drexel University College of Medicine and completed his general surgery internship and orthopedic surgery residency at the Long Island Jewish Medical Center. He completed a sports medicine fellowship at the New England Baptist Hospital in Boston, as well as the fellowship for shoulder and elbow at the Hospital for Special Surgery in New York. He holds an academic appointment as assistant clinical professor at the Tufts University School of Medicine in Boston. If you've noticed, Dr. Saurav has delivered a couple of lectures on our channel and it's already reached a huge audience. And today it's my great honor to bring back Dr. Saurav Shah for this wonderful live program. Over to you, Saurav.
Thank you so much. Wonderful introduction as always. Glad to be back. Thank you for having me. So we'll dive right into it here. We're talking about ACL injury, reconstruction, and return to sport. So some tips for successful ACL surgery. It includes high strength graft with meticulous preparation and harvest, anatomic positioning, rigid fixation, avoiding problems along the way, learning from the past missteps, and don't be the first or last to adopt what's new. So ACL injury and associated cartilage injury, there's always been kind of that understanding that ACL injury leads to cartilage injury. But now we have biomarkers in the blood. So this is the editorial that I actually wrote. It's in this month's arthroscopy. So the study that I evaluated and wrote an editorial on, it found that serum comp, collagen oligometric protein, may be detected for earlier osteoarthritis in patients with ACL deficiency. So they found in their multivariate analysis age and serum comp as independent factors for the presence of early OA on arthroscopic cartilage findings. They used the Atterbury classification during arthroscopy to determine grade 1, 2, 3, 4 in the Atterbury crossing for arthritis classification. So evidence of a relatively benign and cost-effective strategy for identifying early OA in patients with ACL deficiency, right? Well, you may say that's excellent, and it is. It is the first step, and that's where we're headed in 2022. This is early detection through the blood. But you have to kind of be aware of the confounding factors here. So serum comp can be elevated not just in cartilage damage, but also in synovitis. This is particularly misleading in patients diagnosed with rheumatologic conditions or undiagnosed genetic HLA-B27 variants. So, next step in progression is what are the factors for ACL failure? High re-injury rate in younger patients undergoing ACL reconstruction. It's a cohort of 354 patients under the age of 20, underwent primary hamstring autograft at mean 5-year follow-up. Graft re-ruptures occurred at 57 patients at average 1.8 years. Half occurred within the first post-op year, and almost 75% within the first 2 years. Highest graft rupture was in the youngest males. The conclusion was early graft rupture is more prevalent in patients who underwent surgery that were younger than 18, and males had a higher rupture rate than females. So that brings us to graft selection. So this was a registry study from New Zealand, the effective graft choice on revision and contralateral ACL reconstruction. So prospective data captured by the New Zealand ACL registry, all primary ACL reconstructions, either hamstring or BTB autograft. 77% were hamstring graft, and about 22% were BTB. Patients with a hamstring tendon autograft had a revision rate of 2.7 compared to 1.3 for BTB. So use of BTB, bone patellar bone autograft, reduced the risk of graft rupture, was associated with a risk of injury to the contralateral ACL. So that's something to keep in mind and advise the patients on. This was the stability trial out of Canada with Alan Getgood, AJSM 2020, multi-center prospective randomized control trial. The biggest knock on this study was it was only hamstring tendon. So if you're going to use hamstring autograft, you should do an LET with it in patients under 25. So they looked at under 25 and at least 2 out of 3 criteria: grade 2 pivot shift or higher, pivoting sports, or generalized ligamentous laxity. For the most part, these are the patients that you're doing these ACLs on. And if you take care of any schools or high schools or that type of thing, these are the high-risk patients. The outcomes were failure, and they found that addition of LET to a single bundle hamstring tendon autograft. Again, that's the other thing. It's a single bundle hamstring tendon autograft in young patients. High risk of failure results in clinically relevant reduction in graft rupture and persistence of rotatory laxity. So adding the LET, the lateral extra-articular tenodesis, whether you do a modified Lemaire or you do an ACL reconstruction, adding that in provides better results in terms of reduction in graft re-rupture and persistence rotatory laxity at 2 years. So this was the next studies out of the Moon Group, AJSM 2020. They looked at ACL reconstruction in high school and collegiate athletes, patients aged 14 to 22, injured in sports. There was high-grade preoperative knee laxity, and they found that the autograft type, age, and their preoperative knee laxity were the three most influential predictors of graft revision. Odds of graft revision were 2.1 times higher for those patients receiving hamstring autograft versus BTB. So, multiple studies kind of here showing, if you're going to do young sporting athletes, you should really, really look at doing BTB autograft versus hamstring. So in this study at 6 years, it was 2.1 times higher. So this is a study that I tell my athletes, I take care of Division I and Division III school. I tell them if they have any doubts or they want to kind of, they've heard from their friends that hamstring is an easier rehab or what have you. This is really kind of big time evidence to support against that and to go with, tried and true BTB, because it does have better lower re-rupture rates. And this is evidence of that. So then we talk about return to sport. So this paper is actually still submitted for us from our group. We did a systematic review, and we're able to do a meta-analysis and come up with critical criteria recommendations on in terms of return to sport. So our critical criteria recommended by the authors from our institution, we recommended time since surgery of 8 months, use of more than two functional tests in your return to play protocol. Our recommendation is single leg hop greater than 90% of the contralateral side, the drop jump test, and the pivot shift testing, obviously. But kind of adding to that, psychological readiness to return to play testing, and then strength does play a role. Quad, hamstring, glute index, strength greater than or equal to 90%. So these factors, including age and female gender, were found to be significantly impactful in the likelihood to return to sport or risk of re-injury or both. So the reasoning behind that is kind of, the process it takes for a graft, right? We're asking tendons to become ligaments. And in the ligamentization process, there are 3 phases: early graft healing, proliferation, and then ligamentization. But if you see on the graph here, by the time you get to 3 months, everyone, most of the athletes are begging to kind of push forward and get back into sport. But in reality, that the graft that you put in, that tendon is the strength of the original, is dipping below the strength of the original ACL as it becomes a ligament. So really, the ligamentization process really doesn't kind of begin until, or get back to the strength of the original ACL until about 6 months. So, these studies kind of prove or show that, there is a real correlation between this process and re-rupture rates. So again, just going through the 3 phases: early graft healing, the death of graft cells, no vessels invading the graft tissue, the cells die, but there's no loss of strength initially. That's why it's much stronger than native ACL. And in the proliferation phase, that's the most intense remodeling and revascularization. So during this critical time, the graft is prone not only to re-rupture, but to stretching and elongation. So, a non-functional intact ACL is the same as one that's not, intact. Ligamentization, that's the characteristic restructuring the graft towards the properties of the intact ACL or the original ACL. So again, this happens at different speeds based on the graft type. Allograft regains its strength at about half the speed as the tissue from autograft. So this was the first paper kind of portraying that young athletes who return to sport 4 to 9 months after ACL have a re-injury rate of 7 times versus those that do not. This was out of JOSPT in 2020. So they found athletes who returned to knee strenuous sport before 9 months after reconstruction at a higher rate of second ACL injury versus those that went before. Taking note, though, there was a kind of relatively small number, only 159 athletes, and a large portion had missing responses and did not have muscle function testing. But it does bring about the broader picture, and our systematic review kind of alleviated some of these other concerns, with our large numbers that we were able to obtain between the systematic review and meta-analysis. Brings us to ACL revision, kind of talk about what to do, how to prevent it, and what are the causes here. So, slope has become kind of the go-to and what to look at when you're dealing with the revision process. You should always kind of have that in the back of your mind as, why did this fail? Number one reason is tunnel malposition, but, if the tunnels look pretty good, then you have to start digging deeper and trying to look at, malalignment, tibial slope, graft choice, those types of things. So this was a case, AJSM 2020, case used in 22 patients, two-stage procedure. So they did the slope correction osteotomy first, and then did a revision ACL in combination with LET. So they kind of went full bore on the revision setting. So the mean age was about 27, follow-up about 30 months. Post-op failure was defined as side-to-side difference of greater than 5, pivot shift greater than 2 or 3. Posterior slope was decreased from about 15 to 9, and the side-to-side difference was decreased from 7 to 1. So went from loose to tight, and they really corrected the tibial slope. Slope correction osteotomy in combination with LET is safe and reliable procedure in patients with a high-grade knee laxity and a posterior tibial slope greater than 12. So they were able to restore the joint stability, and good flexion functions were achieved at least 2-year follow-up. This is a recent study from the Mars group, AJSM 2021, association between graft choice and 6-year outcomes revision ACL. So these were all 1,200 patients, all undergoing revision ACL surgery. So we're already, already ruptured once. This is the second time now. So use of an autograft was found to be a significant predictor of having fewer reoperations within 6 years compared with an allograft. So, again, autograft is the cells are able to kind of revascularize and ligamentize at a faster rate and a more reliable rate. That's why it's preferred over allograft in these younger athlete cohort. And then the big take home is BTB and soft tissue autografts had a decreased risk of graft re-rupture compared with BTB allograft. There is this notion still out there that BTB allograft, after you've had a failed ACL reconstruction, meaning theoretically you put in a BTB autograft that failed, then what graft are you putting in? BTB allograft has a higher re-rupture rate. So my kind of go-to, especially in these young female athletes, is if I did a prior BTB autograft and that failed, then my go-to is a hamstring autograft, but to also put in a LET in order to, based on that stability trial, and be able to give them extra rotatory stability and to prevent re-rupture rates. So this was an editorial that I wrote last year in arthroscopy, kind of echoing the similar points I just mentioned. But this paper that I wrote the editorial on goes into quadriceps autograft for all comers. So Dr. X's group, who wrote the paper, they had done quadriceps autograft is effective for revision ACL no matter what they had prior. So including the patients that had prior BTB, he had put in quadriceps autograft for the graft choice for ACL revision. In my experience, again, just to reiterate a little bit, in my experience, young high school collegiate female athletes with primary reconstruction with BTB, they may not be able to tolerate a secondary insult to the extensor mechanism via the quad tendon. So, they already had patellar tendon, BTB autograft, and now you're going to take the quad tendon above it. So these female athletes who are especially vulnerable, hematoma, arthrofibrosis may become big concerns. And then you talk about when you get into higher level Division I female athletes, it may affect their performance as well. We don't have good data on the performance outlook, but that's just kind of what I've seen in my practice. Long-term ACL outcomes. So obviously, it's always good to look at long-term stuff here. So this was the paper that I wrote in my training, AJSM 2017, 151 kind of high-level athletes, BTB autographed, tight. So we separated them by tight and loose, less than 5 versus greater than 5, less than 3 versus greater than 5. Mean follow-up of 16 years. So no statistically significant difference between the groups at long-term follow-up. And then, so the conclusion was preoperative laxity greater than 5. Side-to-side difference measured by KT1000 does not appear to place patients as the worst clinical outcome at long-term follow-up. However, the biggest kind of limitation in our study was we did not have pivot shift testing. So, kind of the gold standard has now become pivot shift testing in terms of determining laxity, but also, functional outcome has largely been defined by the rotatory part, the pivot shift, versus just the anterior, posterior laxity, meaning the KT1000. But it is still used highly in these studies because, when you get long-term studies, that's what they were doing, 15 years ago. So or 25 years ago in this case. So this is AJSM 2021. They actually looked, they had 25-year follow-up with 151 patients. So very, kind of good data initially. And then they had good data follow-up for 25 years. They defined it as less than 3 as tight, and then slightly loose between 3 to 5, and then loose as greater than 5. They found that the slightly loose grafts had undergone revision 30%. So that was kind of a big number, statistically significant, obviously. And they found that, so the conclusion was a slightly loose graft at 6 months after ACL reconstruction increased the risk of later ACL revision and or graft failure, reduced the length of the athlete's sport career, and caused permanent increased anterior laxity, which led to an inferior Ligament score, knee score. And just for a completeness sake, just to cover posterior cruciate ligament reconstruction. This was AJSM 2019, minimum 10-year results, single versus double bundle, clinical radiographic survivorship, 64 patients, primary PCL reconstruction, 28 patients, single bundle, 36 patients, double bundle, anatomic. At final follow-up, all clinical scores showed no difference. Mean side-to-side difference in stress radiographs, osteoarthritis progression were not different between the groups. 15-year survival, 82% for single bundle, almost 84 for double bundle. So bottom line conclusion, double bundle PCL did not show superior clinical results to those of single bundle at long-term follow-up. This kind of gives us credence to the idea that we've kind of long held as, single bundle PCL does just as well as double bundle. This is just an excellent data source in AJSM that we're able to kind of hang our hat on and show our patients that, the single bundle is equivalent to the double bundle anatomic without having, 2 grafts and the extra OR time and level of difficulty, frankly. Multiligament knee reconstruction. This is AJSM 2019, 194 patients, single stage. So, Dr. LaPrade is big proponent of single stage multiligament knee reconstructions for sports related injuries. This is just to go over the evidence here. 18 patients developed arthrofibrosis requiring reintervention. So that's something to keep an eye on. He had 70% follow-up, 194 patients at mean 3.5 years. Conclusion, these results demonstrate single-stage anatomic-based knee ligament reconstruction with immediate postoperative rehab yielded significantly improved outcomes. In addition, there were no difference in outcomes associated with ACL and PCL-based injuries instead of sports-related multi-leg injuries. Thank you.
Thank you, Sarah, for that brilliant presentation, as usual, and review of the most updated literature. Couple of questions from our side.
Yeah, of course.
Sarah, I've been telling my ACL reconstruction patients that return to play is around 6 months. So when I see your data and that particular graph, it looks at 8 months. So what do I recommend now?
Yeah, so that's the study. That's the study that we submitted and we're at revision right now with arthroscopy. So it was myself, on my colleagues here at Baptist, Dr. Amapa, and Dr. Midhofer, kind of other high volume sports surgeons here. We were able to come up with, based on the meta-analysis, these core criteria that we recommend, the critical criteria. And as you alluded to, one of them is 8 months. That's just based on the re-tear rates and the return to sport rates. We had around 5,000 patients in the meta-analysis. So that in combination with multiple functional testing in terms of your return to play protocol, drop test, single hop test, and obviously pivot shift, you're able to better predict return to sport, but not just return to sport. There's two separate distinctions. It's return to sport, but return to sport at the same level is what we're aiming for. We don't want these patients to come back and kind of be less aggressive or even less well performing in their sport. So that's where the 8 months comes in.
Do you think there's a difference between BTB as well as hamstring for this, return to play?
I would say, yeah. Unfortunately, so graft selection did play a role, but getting down, separating out the graft and return to play, both of them would have been. It was not feasible in this meta-analysis, but graft selection did play a role in the return to sport. So, as it does with re-rupture rates, as we've seen before. So, while however, in our big data, it was statistically significant, but we concluded because of the heterogeneity of the studies that it may not be clinically relevant. That's why I didn't include that in the main results.
Thank you, Saurav. And the other one is regarding the indications for an LET, the lateral extraarticular tenodesis. Now, we have the typical football player who's a forward in the game and who's involved in a lot of cutting movement, right? So I think that is the classical indication where you're going to do a lemur, isn't it?
Yeah, I mean, so I've added it, kind of recently in the past 5 years or so. But what I would say is if you have a pivot shift, over 2, that's kind of the only one what I would do a primary lemur LET. I'm doing all BTBs for all my active young athletes. If you're doing a hamstring autograft, then definitely. I would say for all hamstrings, you should be doing an LET or ACL reconstruction, what modified lemur, whichever you prefer. But you should be adding that to all hamstring autografts in these young pivoting sports athletes. Yes. But for me, I'm doing BTB, so I'm not adding it in unless they have a pivot shift over 2 or it's a revision case.
Okay, so most of your cases are primarily BTB. So what are your indications for a hamstring? Because generally people do hamstrings and reserve BTB for select cases. I mean, you are more into research, so you know better.
Well, that's what these kind of talks are for, right? In order to make the change in the world, you got to have them read the data here and kind of go through it. So my young, I take care of Division I, Division III school. All these kids are getting BTB, and then I have all the girls ask me, oh, but I've read about the knee pain, I've read about this. So I actually, when you take the core reamings from the tibia, you save them and put them back into the bone, and you actually close the periosteum over top of the bone. I've had minimal issues with knee pain, anterior knee pain. But my indications for hamstring would be if it's a revision case, right? So I have, I get sent all the cases from outside, right? Only none of my athletes have retore. It was one non-athlete that at a frat party, kind of had an incident, fell down the stairs. That was the only retear that I've had. But from my indication for hamstring would be revision cases. So, if he had a prior BTB done and that retore, then that's getting a hamstring autograft. Or if you're over 30, 35, but less than 50, and you go, ski, I'm in Boston, so skiing is big here. Skier, cross-country skier, but don't want to go through the BTB rehab, then it's reasonable to do a hamstring autograft. Some kind of community guys or some people who maybe are in the ambulatory surgery center, they want to kind of move faster, they go all allograft over 40, but there was a Moon study looking at revision rates, retear rates over 40, still 1% higher if you do allograft versus autograft. So I've moved mine to 50 in terms of when to do allograft. It's under 50 is still auto, but it would be hamstring.
Thank you, sir. I wonder there could be a study on, there should have been a study looking at this, with a survey at all the AOSSM members and what is their primary graft choice in ACL. Is there something that you're aware of?
So there is one ongoing right now. So I'm participating in that as well. But what I would say is the preliminary results would not be hamstring. It's really kind of almost even split now between BTB and quad autograft. So the quad autograft is a good graft. It's very kind of thick. It's very sturdy. It's single. Obviously, there's no double. There's not multiple bundles in terms of preparation. But it's not. It's a more challenging, meaning more meticulous harvest. So I think that may be deterrent for some people. I've just had good results with BTB, so I haven't found the need to switch, honestly. But if you look at the survey, it's ongoing right now. But if you kind of survey the country, it would be BTB versus quad auto, not necessarily hamstring.
And I've done a couple of quads, and I found the length is sometimes an issue because you have the adequate length, and by the time the upper end, you reach the upper end, it's already muscle. So that's a particular issue that I found in my cases. Any comment on that?
That's where I was getting into the technical. It's more technically demanding to maximize the length, but then on top of that, then you have to do an all inside, meaning you have to use the newer devices with the retro drilling to build sockets, not tunnels, and then you're relying literally, in some cases, if you have a short tendon, you may only have 10 to 15 millimeters inside the socket. So is that really enough for long-term fixation? We have yet to see that adequately, but the short-term results are pretty good. It is a more technically demanding procedure in terms of making sure you have adequate length and adequate fixation in those short sockets.
Thank you, sir. And you mentioned about double bundle PCL, right? So what about double bundle ACL? What is the trend in the US? Again, if you look at the data, of course, Freddie Fu.
Yeah, so there's a good, God rest his soul, Freddie Fu actually, had published that. They looked at double bundle, and then some of his colleagues in Pittsburgh, they looked at double bundle versus single bundle ACL at 15-year follow-up, and there was still no difference. So biomechanically, obviously Dr. Fu did a lot of work on that biomechanically and showed that double bundle does recreate the anatomic biomechanics more accurately. But when you look at clinically, 10 and 15-year follow-up just didn't bore out.
Thank you, sir. I think that's all the questions that we have for this session. Thank you for yet another fantastic talk, and I'm sure this is going to benefit a lot of people. Thank you so much, sir.
Thank you. Have a good day.
Bye-bye.